Right, I think we're going to be ready to begin, as long as everybody's got their food. And I want to welcome you and say good evening, and thank you for coming on your time off. For those of you who don't already know who I am, I'm Valerie Frendel, the Clinical Documentation Coordinator for Riverview Hospital. I work primarily on the inpatient side with our hospitalist group. I'm going to introduce our speaker tonight, Dr. Victor Freeman, but first I need to just remind you of all those little housekeeping items. First of all, we're going to be offering CMEs for this activity, so as long as you sign in and turn in your evaluation form at the completion of the presentation, you will get your CMEs awarded for tonight's presentation. Second, there's another form on your table that is a list of modules. These are the modules that Riverview Hospital has purchased from J.A. Thomas for ICD-10 provider education. It's an exhaustive list of virtually every specialty and role there is. Each of the modules is about 50 to 60 minutes long, and they are at a depth and detail level that I think you will find very helpful in giving you the comfort level you need to understand the detail and the type of documentation that's going to be requested of you at the time of the ICD-10 conversion. So if you're interested in viewing your modules, just circle the modules that you'd like to watch and give me your contact information, and I will be happy to get those set up for you and get you access to be able to watch those from anywhere, from any computer. There's just a URL link to see those. Also, if you leave me your contact information, even if you don't want to, if you elect not to view a module, if you just leave me your contact information, I will send you Dr. Freeman's presentation to have afterwards. And finally, I just want to let you know that for the ICD-10 preparation, you can expect to be seeing just after this kickoff event, this presentation, we'll be doing flyers, we'll be doing provider tip sheets for role-specific tips for documentation. Those kinds of things will be coming out in the upcoming weeks and months as we ramp up to the October 1st go live of ICD-10. So on that note, it's my great pleasure to be able to introduce our speaker tonight, Dr. Victor Freeman. Dr. Freeman, I'm just going to tell you a brief background. He received his Bachelor's of Science degree from Harvard University and his Doctor of Medicine from Stanford University School of Medicine. He completed graduate work in economics from Stanford School of Business as well. His residency program was in internal medicine and was completed at Mass General Hospital. Dr. Freeman also holds a Master of Public Policy in Ethics from Georgetown University. As an expert on U.S. healthcare policy, he brings a unique and diverse professional background to his role as Regional Medical Director with J.A. Thomas & Associates. He's a national speaker on healthcare reform, on clinical documentation improvement, and the ICD-10 transition for the healthcare industry. We are very fortunate to have him here with us tonight and learn from his expertise on this subject. So please join me in welcoming Dr. Freeman.
Thank you very much. It is a pleasure to be here. This is my first time actually in Wisconsin. I've got a whole bunch of orders for cheese heads I got to bring back. I haven't figured out how to do that. But I'm glad to be here to come to you and share with you really what's going on in D.C. that's driving a lot of the things around documentation, but more specifically around the issue of ICD-10. As you can see at the bottom here, I did spend a little time in the federal government. I, in fact, was in with something called HRSA, the Health Resources and Services Administration. And that was actually where I introduced that agency to the issue of ICD-10. I heard something about it coming. I asked my boss if I could go learn about it. She said it was not important. I said I still would like to learn about it. So because the conference was local, I went and I came back and I told her, I think it's going to be a big deal. And she said, no, I don't think so. And I put it away until the Secretary of Health and Human Services said, I want to know who the point office is in each agency for dealing with this, and it was our office. So I've been immersed in ICD-10 for quite some time, but I also come from a lot of different hospital backgrounds, so I'd like to be able to share with you what's going on. First thing is, most of you don't realize how many ICD-9 codes there are. There's actually 19,000 of those codes right now, and if you do not know your coders, you should get to know them. You should give them big hugs because they're managing 19,000 codes with very strict rules on your behalf. Unfortunately, no one ever told us that there are very strict rules on what coders can and cannot code. So we think that everything we say and do is codable, and it's not. And the problem is many of us have been resisting the notion of learning the appropriate codable terms for capturing medical necessity and severity of illness. And that's going to become a bigger issue for us as we go into ICD-10. So let me just start there with the 19,000 codes, because I want you to understand that codes are not just about billing. This is Marilyn Tavener. She was, at that time, the acting director for the Center for Medicare and Medicaid Services. She was announcing even back in 2011 that they were going to be putting out report cards, not just on hospitals, but also on doctors. Those report cards are all based on codes. The only people reading what you write are the coders, either in your office, or in the billing department, or in this hospital. So there's a real push right now to get data out there to folks. How many of you heard of Physician Compare website? It's more than most, like 4, okay. It's important that you do recognize that if you see Medicare patients, your name is up here. Now, it is a government website, so it might not be accurate. And I do know that it also might be quite outdated. But whether you are a medicine person or a surgeon, you will appear on this website. And you're saying, well, what's the big deal? Well, for right now, there really isn't a big deal. The Government Accounting Agency, GAO, which is the watchdog, internal watchdog for the government, came and looked at the site and said it's absolutely worthless. Now, we could have all looked at it and told them that ourselves. But the reality is, when a government agency gets a scathing report like that, they realize they've got to put data in here. So typically in the area where you're seeing things like quality programs, you're going to be seeing more and more numbers. The way things work in the federal government, they'll start putting things in 2016, but they'll be using 2014 data. So if you end up with a bad profile, it may hang out there for quite some time. You're already being profiled. Many of you don't realize this, but more and more of your patients will be learning about it. United's quite proud of their program. They look at some 25 different specialties, and again, it's all based on codes. I typically come to a city, put in the zip code of the hospital, and look for clinicians that fall into the United Health Premium Tier 1 status. That's considered the people who are highest in quality and cost efficiency. Again, it's all based on codes. But those codes are all driven by whether or not you are using the appropriate codable terms and capturing medical necessity, severity of illness. Now, the first time I did this, I was very impressed because all I saw was a whole page of United Health Premium Tier 1 folks. I was like, wow, what an impressive town. Until I discovered that they front load the website with the Tier 1 people. So when you first go there, it's only going to show the Tier 1 people. And if you go back further and further pages, you will find there may be some things next to your name you don't necessarily want to see. You see, they will acknowledge when they don't have enough data, but they'll also acknowledge when you don't meet their efficiency standards. So it's important that we begin to pay attention to our own documentation, because that's what drives the codes that produce results like these. Here's what they're evaluating people on, but here's the most important part of it, because most doctors don't care even when they discover that they're being evaluated, but you want to recognize they're actually driving patients to doctors with these higher performance numbers. So it's very important that you begin to recognize that there is a growing effort to track our performance based on codes. Right now, we know that somebody's got to be below average. The question is, does it really matter? Well, if I'm managed care and I got a group whose numbers are here and a group whose numbers are here, do I have to pay you the same? The answer is no. And increasingly, you're going to get paid based on those numbers. Now, who needs to be worried? Probably the people initially at the bottom 10%. Because either they're doing lousy care or they're doing lousy documentation, and managed care is not going to care which it is. So these codes are becoming more and more important to us. Many of you think, as long as I'm doing a good job caring for patients, I should be okay. United Health basically said to their Medicare Advantage physicians, to 10 to 15% of them, we want to thank you for your service to the Medicare Advantage program. We will no longer need your services. You do not need to acknowledge this letter. That's all the feedback they got. Now, this has separated doctor-patient relationships that were years old, decades old. Managed care is not going to worry about that because they know that patients will go where the wallets tell them they have to. So again, we've got to begin to pay attention to what's going on with codes. So as we go into ICD-10, you have to recognize there is a lot of politics there. Here's Marilyn Tavenner again. At this point, she was, in fact, the administrator for Centers for Medicare and Medicaid. This, by the way, is one of the biggest meetings that occurs in the United States. 40,000 attendees back then. This is well over a year ago, probably like 50 months ago. And she made a big announcement back then. She said October 1st, 2014 was going to be the date. It's going to be no delay. That's what she announced. She got a standing ovation. We know that didn't happen. So the question is, what did happen? Politics. House of Representatives was looking at a bill called the SGR. How many know what the SGR bill is? Handful, okay. Basic Sustainable Growth Rate. It basically was a law that never got implemented. What it said, though, was if physicians do not control Medicare costs, they'll take an across-the-board cut in pay. Well, the law kept getting kicked down the road, and the penalty kept growing and growing, and it would have been 25% if they'd actually implemented it back then, but they didn't. There were 90 organizations trying to fight it. They're saying, this is silly, stop holding it over our head, let's get rid of this. But the House Representatives said, no, we really want to have a little fun with the Democrats, and how about we throw in an ICD-10 delay? Will that placate you? It turns out it placated none of those organizations. But the House of Representatives put it forward anyway. Why would they do that? They wanted to see what the Senate was going to do. You see, they were able to move this through in 30 seconds, which is an absolute record. Many of the members weren't even in the chamber at the time. And in fact, conservatives like Tom Coburn are saying this is not a good way to do legislation. But again, politics is what was driving everything. And they recognized that they wanted to see what the democratically controlled Senate and the president were going to do. And we know the Democratic Senate passed it, and the president passed it in the middle of the night on April Fool's Day. Now, they tell me Secret Service had to go and sedate Marilyn Tavenner here, because she was quite livid about it. There were a lot of physicians that did applaud this. It was a stunt, basically, because October 1st would have come right before the midterm elections. And the Democrats did not want physicians screaming about ICD-10 right before those elections. So it was a good stunt. It worked. The problem was it cost us well over $1 billion. A lot of that is in retraining costs that now have to go on. Some lost fraud recovery, because we need a more detailed system to catch fraud. And then there was also a greater level of acuity that could have been captured on ICD-10 that's been lost. So it was a very expensive game that got played. By the way, Marilyn Tavenner did get even. Remember, it was April Fool's Day when the president signed. By April 3rd, she'd actually managed to disclose all of our payments in Medicare. There's actually a bigger deal than you think. You see, it turns out there'd been a 33-year injunction against releasing the details of what each of us gets paid by Medicare. This is now released to the attorneys general of states, to insurance companies, to anyone that basically wants to understand who's making big money off of Medicare. The ultimate goal is to match the clinical outcomes to the incomes and see the value that they're getting for what they pay. The date that the law said was that it cannot be implemented, ICD-10 cannot be implemented before October 1st this year. So CMS changed and said, okay, we're going to make it October 1st this year. I have found when I talk to most audiences, half the physicians don't know that date, and those that do know that date think it's going to get delayed. How many of you heard of the Coalition for ICD-10? Okay, you need to know about this group, because for all you people that are holding out hope that the bills that are flurrying around Congress are going to make a difference, you need to know who's now organized. The hospital industry, health insurance industry have now coordinated, and they're investing millions of dollars in to make sure this ICD-10 goes forward. They've now got the highest paid lobbyists in D.C. working on their behalf. The Government Accounting Agency came in because Congress said, we want to know whether or not CMS is actually ready for this. And the Government Accounting Office says, yes, CMS is ready. The materials they have are appropriate, so we should move forward. As a result of that, Senate said, okay, we're on board. We believe we should go forward. Even the House subcommittee, and there have been several hearings there. By the way, the Coalition for ICD-10 stacked the lineup. So everyone there is saying it's too expensive to delay this again. The House has been very clear about that. I don't know how to convey to physicians that you need to be getting ready for this. It's very real. It's going forward. The Coalition for ICD-10 is fighting every bill that's coming up right now. And the House Republican leadership has made it clear they're committed that everything's going forward. So if you hear people talking about a buzz of, I heard a new bill, I heard this, please pass this information on to them. Most of those bills, some of them are rehashes of old bills, and they didn't even get the same number of responses that they got the first time they came up. They still have to get through committees, and most of those committee chairs don't even want to hear them. So if you're betting your practice on a delay, you're going to be in trouble. Please pass the word on. Let's now get into ICD-10. Remember I told you got a lot of coders that are working on your behalf? Many of them are going to simply retire. Because in ICD-10, they actually have to learn anatomy, and they also have to learn the rules on a whole lot more codes. Now, that may seem overwhelming to you, but let me tell you, every year the Oxford Dictionary adds hundreds of new words. You don't worry about it. You worry about the words you're going to use. And that's the approach you should take. You worry about the diagnoses and the procedures that you do, and you want to learn those. And you've got modules that will help you do that. How many of you have paper records? None of you. One guy in the back. Okay. You probably know folks have paper records. Here's the message for them. This is your typical billing sheet. It's usually got the patient information, everything up front. It's usually a two-page thing. So you've got all your CPT codes, and on the back is the ICD-9 codes that you write on the front. This is what it looks like in ICD-9. This is what it looks like in ICD-10. You're saying, well, this doesn't seem like a big deal. I don't see why you're making a big deal out of this. Well, this is pages 1 and 2, 3 and 4, 5 and 6, 7 and 8, and 9. So if you're going to continue on paper, you're going to have to find a way to make the conversion of those 9 codes into 10 codes. There is something out there called a GEM system. It is not an easy system to use. You need to be talking with your specialty society, figuring out if they're going to help you with this. Talk to your colleagues, figure out how they're doing it. If you're going to stay with paper, it does offer some special challenges. Now, what is this thing called ICD-10? First thing to understand, it's an international classification of disease. It's actually been around since 1900, when there was ICD-1, and we were tracking basically mortality in the world. We've added in morbidity in the world, and so it's a World Health Organization, and we're looking at the 10th revision of it. Now, we are the only ones in the world that use it for billing, so we had to do a clinical modification of it. Now, our modification is the most detailed version of ICD-10 in the world. I can tell you that having taught in Dubai, where they really wanted to learn about the Australian version, which isn't as detailed, but it turns out in the United Arab Emirates, they do use our version, so they were quite floored to learn how detailed it actually is. They don't even have a mandate for it there, but they think it's a good system, and they want to move forward with it. Now, because we, again, use it for billing, we need to have a procedural code system. So those are the two parts of ICD-10 in the United States. The diagnosis part has actually been used for well over 10 years by the CDC for reporting our mortality statistics, because they needed to be able to compare them with what's happening in the rest of the world. So the CDC has been using ICD-10 for quite some time. PCS is going to be for the hospital to be able to bill. Please pay attention to this one point. Physicians will always use CPT codes, inpatient and outpatient. It is the hospital that will be using PCS codes. So you will need to learn to document so that they can complete all of their coding, but you will still be using your CPT code, inpatient, outpatient, CPT code. And that was a deal struck by the AMA board. They love the CPT coding system because it makes them a lot of money. So they made a deal with CMS. They said, how about we keep the CPT code and we support your ICD-10? CMS said, deal. The problem is AMA House of Delegates actually rules. So AMA House of Delegates said, we hate ICD-10. So the official position of the AMA is they oppose it. Politics. By the way, we are not leaders when it comes to ICD-10 adoption. We are way behind the rest of the world. Now, some of you may be saying, well, you know, we didn't adopt the metric system either. Okay. We are going to be adopting ICD-10. It is actually quite essential that we do. Some of you are saying, why? Bottom line is the 35-year-old system. It's got problems. A lot of the things that are in it are outdated and obsolete. We're getting inaccurate and limited data about what's going on with our patients. It is not very specific. It's still very general. We're not able to do any international comparison because we're talking a different language of coding. Here's the key part, though. The ultimate goal is for you to have very specific ICD-10 codes in your electronic medical record that allow you to analyze what's happening with your own patients. So if you're a surgeon, you want to be able to track complications, you're going to be able to do it with ICD-10 codes, far better than you would be able to do it with ICD-9 codes. If you're in internal medicine, family practice, you want to see what's happening with your diabetic patients, your heart failure patients, you'll be much better able to do that with an ICD-10 very specific data source. Here's a big thing for the government, fraud and abuse. Right now, I break my hip. You fix my hip. I'm back in the hospital within 1 week with a broken hip. I cannot tell if it's the same hip with an ICD-9 code. With an ICD-10 code, I not only will know if it's the same hip, I will know if the break is in the same part of the bone from one code. Because that's the level of detail we're going to in ICD-10. So tracking fraud and abuse, or identifying it, is a very important goal for the government. The reason they will not give up on this. Biosurveillance and public health is also very important. Turns out there is no code for Ebola. That's how old the system is. So we need something that's more up to date. So we're speaking the same language as the rest of the world, because bugs love to travel on planes the same way we do. We also need it for reporting, quality measurement, quality improvement. We need a detailed system to understand what's happening with our patients and for us to be able to do analyses to help us understand how to better care for patients. Let's talk about some of the differences now. Obviously, we mentioned the fact that it's more specific. It actually makes more clinical sense. The words STEMI and non-STEMI, how we refer to myocardial infarctions, did not exist in ICD-9. So we're trying to catch up with our own language. It is up to date in terms of all the procedures that we have. More importantly, it easily expands to accommodate new procedures. We're going from an all-numeric system to an alphanumeric system, and we're expanding the number of characters. And someone was asking me earlier how to become an expert in this. I had to go through weeks' further training, a lot of home schooling on books and coding books, and then I had to take a 3-day open book test, which I actually had to cram into 8 hours. Not a fun activity. It is a lot to learn, but there are some interesting parts of how the codes are set up. One is many of the codes have a hierarchical structure. If I want to understand the concept of tuberculosis, which is a separate category now, that's A15 to A19. So all the categories are just 3 digits there. But as you add details to categories, you get more and more detail. So here there's an anatomic specificity that comes as you add more characters. So there is a nice hierarchical logic to a lot of the codes that are there that will really help us in better understanding disease. Also, some things that even seem pretty small to us are a big deal to the government. Pressure ulcers is one of those. If you admit a patient with a stage 3 or stage 4 ulcer and you neglect to get wound care for that patient, that's actually considered a reportable event. They take patient safety and patient care very seriously. Right now, we've got just 9 codes for tracking pressure ulcers. We are going, and it's based on the site only, we're going to 125 codes. You're saying, how could you possibly go to 125? Well, we're getting much more specific about the site, but we're also adding in a new concept in coding for us, left and right. Now, you'll hear exaggerations out there about how much left and right actually affects the codes. About 25% of the increase is due to laterality, left and right. But we're also adding something into that same code called the stage of the ulcer. So whenever you've got a skin ulcer, diabetic ulcer, pressure ulcer, whatever that is, you're going to be expected to give them some sort of staging for that, because we need to be able to track what's happening with those wounds. Many of you memorize your codes because you use just a handful of them. I'm telling you now, those days are over. Mid-cervical femoral neck fracture closed. There are 12 available codes for that in ICD-9. In ICD-10, there'll be 576. So your little cheat sheets will probably be going out the door. Saying, how is that even possible? We're still going to describe the fracture, a displaced mid-cervical fracture, but we're adding new information into the single code. Right or left, remember we got to include that laterality. Now there's something called a subsequent encounter. Now I have to stop here because this is a concept you cannot leave here confused about. There's initial encounter and there's subsequent encounter. Let me give you a non-fracture example. I cut my hand badly. I go to the emergency department. They go, oh, that looks horrible. They clean it as best they can. They patch it up. They say, you need a hand surgeon. I go out. I see my primary care doctor. He says, yuck, that's disgusting. Let me get you the hand surgeon. Here's a referral. I go to the hand surgeon. He goes, yeah, that is pretty bad. Let me get you in the hospital and operate on that. I'm in the hospital 3 days. He operates on day 1, sees me day 2, sends me out on day 3. All of those are called an initial encounter, even the 3 days in the hospital. Because the term initial encounter means during the acute treatment phase. So all of those were the acute treatment phase. Once I leave the hospital, everyone I see from then on is a subsequent encounter, even if I'm seeing someone for the first time. Initial and subsequent is not about whether we're seeing them for the first or second time. It's about whether or not they're in the acute treatment phase or the healing phase. Now, I discover numbness in my hand. Now, I've got nerve damage now. That's the third category called sequela. Okay? Any lasting effect from that injury is going to be sequela. So there's initial, subsequent, sequela. Now, here's the really good news about this. It only applies to poisonings, overdoses, and injuries. Only place it applies. So don't start asking me about, well, what about heart failure? It only applies to injuries. So that's burns, fractures, any bloody events, and overdoses, poisonings. Only place it applies. We're going to come with the term subsequent again, but for the most part, this is the only place it's going to occur: initial, subsequent, sequela. Any questions on that? Perfect. All right. Now, in addition to that, that's not all we have for fractures. We're also going to add in whether it's open or closed, whether it is a malunion or non-union, built right into that same code. So that is why you have an explosion in the number of codes in fractures. And fractures accounts for about 25% of the increase. All the injuries do. This is what it will look like in a bad electronic medical record. And remember I told you about that meeting where there were 40,000 people? Well, I went to the meeting this year. There were 49,000 people. And I spent my time going to all the electronic medical record vendors to see how they were handling ICD-10. The good news is I only found 2 of them that were doing something this stupid. The rest of them are working with, oh, were they?
Who were they?
NextGen. The interesting part was most of the other people I talked, well, Practice Fusion also had no idea about what to do at all. So that's another group. But most of the electronic medical record vendor folks had already recognized they needed something to help physicians with this. So they're working with 1 or 2 companies. One's called IMO, Intelligent Medical Object. The other's called HLI, Health Language Incorporated. And both of them are data dictionary people. And so what they have both done for most electronic medical records that are out there is they set up a system. So you put in a trigger word like fracture, and it will guide you through to get the right code. It will ask you a series of probably up to 5 questions that will get you right to the right code. And that's how it should be done. Same thing's going to be true with diabetes, and we'll show you that also. But just to show you, this is what NextGen did. Now, I said, this is crazy. No physician's going to go through all this to find this, especially since in this particular case, I did count the number of lines, and it would be 18 pages of this. So nobody's going to do that. And that's what I told the guy. Now, he's a poor sales guy. And I said, that's crazy. He said, well, we're working with IMO. And I went, what? So I went to the IMO booth. I said, NextGen says they're working with you, and this is what they're showing me. they said, look, they won't license our technology. So you can come to us, and we will install an app that will correct this on their machines. What can I say? Hopefully, by the time I'm done here, most of the EMRs will recognize this is not workable and will have made the appropriate adjustments. But you want to make sure you're getting on top of this for your office sooner rather than later. Now, some codes have actually condensed in numbers, so I don't want you to think that everything is expanded. MIs, I've gone from now 30 codes down to just 14. So not everything is blowing apart. And we're actually just using more of the current language we have. STEMI and non-STEMI. They want you to know basically what part of the heart's being affected, and ideally they want you to list what the artery is. As a general rule, we're able to do a good job of that, even just with an EKG. But obviously, if it's been cath or something else, we really want to be able to get that level of detail in there. So not everything is expanding beyond all imagination. Now, remember I mentioned the word subsequent. The word subsequent does come up in myocardial infarctions because you can have a subsequent MI, and that is a separate code. Now, it used to be 8 weeks, and now it's going to be 4 weeks. So this is one of those things you just want to memorize and know. Even if you're not in cardiology, you'll want to make sure you understand the difference between a subsequent MI and a new MI. So if it's within 4 weeks, it's called subsequent. And if it's outside of that, it's a new MI. And that may be relevant because you're maybe doing whatever your subspecialty is to that patient, but this is an important comorbidity you want to capture. It's not just about your primary diagnosis that you work with. You also want to be able to capture comorbidities whenever possible. Now, if you're consulting on a case, you can focus on your subspecialty area. But if you're the attending of record, you want to make sure you're not only paying attention to your primary diagnosis, but also all the comorbidities that go with it. Hypertension is also an interesting one. 33 codes there, now down to 14. What we're getting rid of is the terms malignant, benign. That's the critical concept there. You can see we're still looking at all the manifestations now, but there are complications in here that we've got to go into because they're not intuitive to us. Hypertension with heart disease. You want to memorize this phrase. It's going to be a very important one. You are only going to use it if you believe their heart disease is due to hypertension. And the code is going to look for you to specify that hypertensive heart disease is a causal relationship. I'm admitting this patient with heart disease I believe to be caused by their hypertension. Obviously, that's typically going to be happening with a patient with heart failure. So they will wait for you to demonstrate that causal relationship to make that determination. But when it comes to chronic kidney disease, it will be assumed. So if you have hypertension and chronic kidney disease, it will be assumed. And that's the automatic code it's going to get. So, controlled and uncontrolled, you can still use the language. It has no impact on coding. Let me just show you a case. So here's a 68-year-old male, admitted diagnosis of hypertension, heart disease, CHF, stage 4 chronic kidney disease. So if that's what we say, here's what they're going to be trying to figure out. Okay, is this hypertensive heart disease with heart failure? Got to give enough information to know, again, that that heart disease is due to the hypertension. So you've got to make some statement in there that indicates that, if that's your belief, because that in itself is its own code. CHF, obviously you still have to say whether it's acute or chronic, systolic, diastolic, or combined. When it comes to kidney disease, you will need to know the stage. And I'll talk about how you get there toward the end. So if those are the concepts we've got to tease out there, here's what the coding is going to be. Hypertensive heart and chronic kidney disease with heart failure. That's one code. That's one code. But because the terms heart failure are there, chronic kidney disease, there must be accompanying codes. And those accompanying codes must give us more detail. The chronic kidney disease must be staged. In this case, stage 4. And the heart failure has to be specific. In this case, acute on chronic, diastolic heart failure. So these are going to be important concepts for us when we're talking about hypertension, heart disease, and chronic kidney disease. So some cases we know have truly exploded, fractures being one of them. If we look at something like the fracture of a femur, it turns out that there are 2,466 codes just for the fracture of a femur. So you're like, well, how am I possibly going to learn this? Head and neck, base of the neck, displaced left fracture, subsequent encounter, all that other stuff. Well, the reality is you don't have to memorize anything except these concepts. You want to be anatomically quite specific. What bone was it? You definitely want to know if it's open or closed. Because if it's open, you're going to be using the Castillo grade to evaluate it. Closed, routine or delayed healing, non-union, malunion. If you memorize those concepts, then you know whenever you talk about a fracture, you've got it all covered. You just have to remember subsequent and initial encounter, and then plug all those in. So again, you're not going to be memorizing codes. You're going to be memorizing concepts. And the modules that you go through will teach you these. Here's the language you're going to be using. Subsequent encounter for a non-unit of a displaced fracture of the base of the left femoral neck. It turns out that orthopedics is really up in arms because they saw these expansion of codes. This is not much different than what they already said. So we're not really changing their language as much as we are catching up with the language they already use. Some of them change in terminology. Asthma is one of those. But again, it's keeping with the literature. The terms now are mild intermittent, mild persistent, moderate persistent, severe persistent. Now, here's the thing you need to understand about codes. They will not keep up with the medical literature. So as asthma changes and you refer to it a different way, don't expect the code to change. It doesn't happen that fast. There are things called coding clinics. If doctors get mad enough, they go to the coding community. The coding community goes to the hospital association. They go to CMS, Center for Medicare and Medicaid Services, and they negotiate changes to the codes. But that can take years. So here's where we are now. Some things have a change in terminology and an expansion. Diabetes is one of those. Diabetes has something that's very frustrating. They're called combination codes. And I'll show you what they look like. But the issue of controlled and uncontrolled, again, is not relevant for coding. I didn't say you can't use it. I just said it's not relevant for coding. They do want you to capture what was the cause of the diabetes, what type of diabetes it is. So the number one issue becomes going from type 1, type 2, and secondary to type 1, type 2, what's the underlying condition, what's the drug or chemical, or what's the other reason they've got it. So you can see an expansion from 60 codes to 206 codes, but it's because we're getting that detail in on what caused it. Now, the real question becomes, what's going to be a reimbursable code? Can I still just write diabetes? The real issue is we do not know whether or not managed care is going to pay for pure generic codes, because they believe there's a certain level of detail you as a physician need to know in order to be providing care. So if this is your primary diagnosis, diabetes sitting by itself is probably not going to get reimbursed, because they expect you to at least know if it's type 1, type 2, or what the cause is. Now, if you don't know it, you don't know it. In certain environments where it's just going to be true. For example, if I'm in the emergency department, I'm trying to see a rapid number of patients, the person tells me they're diabetic, I can make a presumption. Have you had this since you were a child? Are you insulin independent? That gives me some clues. Doesn't guarantee anything, but that gives me a working diagnosis at least. I have to be doing that anyway. When it comes to diabetics getting into trouble, if they're type 1, it's called ketoacidosis. If it's type 2, they're called hyperosmolarity. And in both these cases, you have to specify if it's with or without coma. If you do not want to get a call from the coder, please specify with or without coma. My goal is to teach you the tricks that keep you from getting the calls, because I don't want your practice disrupted. Now, things are going to get more complicated over time as we try and capture complications. Initially, you may be able to come up with a good presumption on whether they have neurologic, kidney, or circulatory complications. But as we get more specific, you're going to need your subspecialty pals to begin to put this in the medical record so that you have these diagnoses. This will happen over time. No one expects you to have this on October 2nd. But there will be an expectation over the next year or two that we're getting down to this level of tracking of what's happening with patients. Let's now talk about PCS codes. Again, you will never use a PCS code. However, while you're focusing on your CPT coding, the hospital has to use the PCS codes, and each of those codes has 7 characters. Turns out that each of those characters is dependent on your documentation. So if you leave out anything and they can't get one of those characters, they got no call, no option but to call you, because they can't bill without it. They've got to have all 7 characters. So we're going from numeric again to alphanumeric, where each character has its own story to tell. Now, we've got section. That's pretty much everything we do. Falls in one of those sections, medical and surgical being the biggest one. Body system and body part are anatomy. By the way, what we understand to be a body part and what a coder understands to be a body part can be 2 different things. You say, I did an EGD. I did biopsies throughout the esophagus. You will get a call. Because the coder's got to say, was it upper, middle, or lower? Those are all separate body parts, and they generate all separate codes. So you've got to be very explicit on where you indicate things are anatomically. Now here's an interesting one, the root operation. Turns out everything that is done in healthcare falls into one of 31 root operations. All procedures fall into one of those 31. Now, the really good news is you don't have to know those 31. You just have to write what you did. It's the coder's job to figure out which of those it fits into. Then we've got one little book on the little electronic things that will help them. So there are lots of things that are out there to help them figure out which one it falls into. But everything we do in healthcare will fall into one of those 31 operations. Approach. You do need to describe how you got there. And I would not assume the coder should know that because this is how it's always done. Make sure your procedure note or your op note always describes how you got there. Natural orifice, endoscopic, percutaneous. Please make sure you're describing what device you use by its function or what it's made of. Brand names will only get you into trouble because no one's telling coders what brand names mean. Okay? There are always going to be qualifiers that help refine everything. So they're going to be counting on you to make sure you're putting the detail of everything you're doing. So I want to show you what the sections look like. As you can see, medical and surgical is the biggest one, but everything is in there. Chiropractic is in there, osteopathic, you name it. We do it in healthcare, falls into one of these sections. So whatever your area is, you'll be doing things in different sections. Obviously, delivering babies, it's mostly going to be in the obstetric section. If you're giving fluids or red blood cells to people, that's going to fall in the administration section. Coders will be more responsible for learning this, though, not you. Your job is to document well. Here are the body systems. Now, I highlighted muscles and tendons because we tend to use certain phrases like, he tore his rotator cuff. If you use the term rotator cuff, you're going to get a call. Was it muscle, tendon, or both? Small concept, but my job is to save you from getting the call. Okay? Root operation, here they are, by the way. Those of you that were curious as to what the 31 root operations are, here they are. Everything we do in healthcare falls into one of these. Some of the things we do actually includes multiple root operations, but just want to show you what they are. You don't need to know them, but the coders will take whatever you do and fit it into one of these. Again, here's our rotator cuff. So now we're talking about, where was it? It was on the left, so it was the shoulder muscle on the left for the rotator cuff. Here are all the approaches. So far, we don't have any new approaches for how we get there. And we know that many of these approaches don't apply to everything, but these are all the possible approaches there are. And so they're going to be codes for wherever these are appropriate for whatever procedure we do. You need to make sure that you are using appropriate language to specify what they are. Sometimes our definitions are very precise for the coders, but they don't correspond to what we believe because, again, we see something differently in terms of body parts. A resection, by definition for the coders, is all of a body part. And excision is a portion of a body part. Why is that a problem? Well, it's a problem mostly because we say TURP, and we say transurethral resection of the prostate. Are we removing the entire prostate? No. So the reality is that's going to be considered an excision. Here's that good news again. You don't have to change. The coders need to know that. Okay? It doesn't become a resection until it's a total prostatectomy for them. And at that point, they also have to record whether or not you're taking out the seminal vesicles. So they will make this change. I'm going to show you, there are lots of different devices that are out there. Again, you want to either describe what its function is. Was it eluting, drug-eluting, non-drug-eluting, radioactive stent? Was it a pacemaker? Or if you're putting in a joint, what's it made of? Was it cemented, not cemented? So be very precise about your devices there also. And of course, there are going to be different qualifiers that apply to everything. And there's no uniformity in how the qualifiers are designed, so I can't really take you through that. Even if you're internal medicine folks, hospitalist procedures, a lot of things you do may get coded. I can't guarantee you that. Mostly hospitals are going to be focusing on coding the big procedures, the things that might change the DRG. But you should always make sure you're documenting appropriately, so again, you don't have to get that call. Even something as simple as an abdominal paracentesis. Medical and surgical is now my section. And my body system is the anatomic region, general. It's a drainage. I got to specify that, by the way. I'm in the peritoneal cavities, my body part. How was my approach? Percutaneous. In this case, I'm not using a device. Why am I not using a device? Because needles, scalpels, scopes are not devices for the purpose of coding. A device is something that is left in the patient. So your pacemaker and the leads are devices. But for our purposes, needles, scalpels, scopes are not considered devices. They're not left in the patient. By the way, no one is tracking sutures or clips. So don't worry about those as devices, okay? In this case also is going to be diagnostic. That's the qualifier now. Let me just show. Here's the language. You did a diagnostic percutaneous abdominal paracentesis without a device. That's the language that will avoid you getting any calls. You have to specify that it was diagnostic because it could have been therapeutic. Okay? You have to specify how you got there. You weren't using a scope or anything. You just went percutaneous. And that's it. It's not very complicated. Here's what the coder is looking at. You'll probably never see this, but I want to show you what they're looking at because they're looking over there to try and figure out what things to add on: percutaneous, drainage device, diagnostic. So they're looking to see what's going on. Even something as simple as a central line. Now this one's quite annoying to me. I doubt your hospital's really going to be coding it, but here's how the code would get built. This would be the ideal language. It's a percutaneous insertion of what? An infusion device. That's what an IV is, into the left internal jugular vein. Now, even if you're not going to get all caught up in the other language there, be very specific about what vessels you put things in, because that does need to get tracked. Okay? Here's what they're looking at again. If you left something in there, there'd be an intraluminal device. Now, colonoscopy, biopsy, rectal, and sigmoid polyps. Again, coder's going to build it. Now, what are they going to do next? Are they going to call you? No. They're simply going to build another code. Why are they going to build another code? One code is for the rectum, one code is for the sigmoid because those are different body parts to them. But you said the right thing. You said where you got your polyps. So you've given them all that they need to know. They will use that same information to build 2 codes. Now, most of you are not doing this correctly now. It's going to get even harder as we move forward. For some reason, many of you resist the word respiratory failure. Please retire the term respiratory insufficiency. Please never use it again, because it does not serve you at all. You want to be getting credit for when your patients are sick, and respiratory insufficiency gets you 0 credit. You do not have to be on a vent to be in failure. If I am gasping for air, by the way, that's acute respiratory failure. I've made my clinical assessment. Acute respiratory failure based on patient gasping for air. I don't even have to use numbers. I could say 88% O2 sat on room air. That would be the clinical criteria. But you have 2 options whenever you put down a diagnosis: your clinical assessment or the clinical criteria. But that's what backs up your diagnosis and makes it something that can't be challenged. If you're throwing in diagnoses because you just want to get credit for severity of illness, auditors are going to come looking and say, prove it to me. You cannot say, see lab sheet, see vital sheet. It needs to be in your note. So you want a codable diagnosis that captures severity of illness, and respiratory failure is one of those. As we go to ICD-10, you've got to add something to it, whether it's hypoxic, hypercapnic, or both. That's going to be an expectation. Well, my surgeons, well, how am I going to know if it's hypercapnic? Well, probably they came into the emergency department, somebody knew they had a CPD event and did an ABG. So you'll know. Okay? There are certain ones you're still missing right now. Being on home O2 has a diagnosis. It's called chronic respiratory failure. Why aren't you getting credit for that? If it's really mild, they're just a little short of breath, there is a term. It's called acute respiratory distress. The word acute matters. The word acute matters. So it's got to be acute respiratory distress. Otherwise, you've wasted your time documenting that, because you get no credit for it. Okay? We talked earlier about chronic kidney disease. You will be expected to indicate which stage it is. The simplest way to do that is with the estimated GFR. It is not very accurate. It's the best we can do. So, if they're coming with chronic kidney disease, hopefully someone's doing that BU in creatinine, and almost all lab reports will give you an estimated GFR. So just plug that in with this formula here, and you'll know what stage it is. So it's important that we're paying attention to these little things. They will make life so much easier as we move forward. Now, if you do not know the rifle criteria, please go look that up. Even if you want to use the KDIGO criteria or any new criteria that's coming along, the numbers are pretty much the same. You want to be able to identify acute kidney injury. That's the new term, because people hated acute renal failure unless people are on dialysis. So the new term now is acute kidney injury. You can use either term, but acute kidney injury happens a whole lot more than you suspect. Severe dehydration can give you acute kidney injury. You're appropriately treating patients with rhabdo, but you never recognize the acute kidney injury. And if it was really bad, you're not doing the FENA, you're not checking the CAS, you're not checking the urine sediment to get the acute tubular necrosis, which would be the highest level of damage, other than acute cortical necrosis. So the name of the game is using the codable terms that capture severity of illness and medical necessity. At the end of the day, you will begin to learn this, not just from the modules, but from a process called dual coding. The coders probably, if they're not doing it now, in the next week, couple weeks or so, will be looking at everything you write right now, this summer, and coding it for ICD-10. One, it gives them good practice, and two, it lets them know which of you is not giving them enough detail. So you'll begin to get feedback about who's not living up to ICD-10 level documentation. Now, you're going to study your subspecialty, but you still may have some trouble with a lot of the comorbidities. So the clinical documentation team is also going to be helping you. Remember, they're not here to police you. They are here to help you. Get codable terms that capture medical necessity, severity of illness. And they will shift a lot of their effort now to helping you get ICD-10 ready. The goal is to have you documenting the level of ICD-10 easily by September. So when October 1st comes, you slide right on through. You won't even notice it. Why should you embrace ICD-10? Well, the simple fact of the matter is it's actually just better documentation. You will see your performance scores going up on profiles you didn't even know were being done on you, simply by using ICD-10. How are you going to master this? First thing you're going to do is study what you need to study for your subspecialty. Now, if you have a broad subspecialty like family medicine, there are going to be several modules that you're going to want to look at. But we've broken it up into as many subspecialties as possible. It's going to be a peer-to-peer conversation. It's a physician that did it. He was a MD, JD, MBA, certified coding specialist, and also a HEMA-approved ICD-10 trainer. He did some, 70 modules, and then he retired. I think he was just exhausted. But he really wanted doctors to know what they needed to know from a documentation point of view to get through ICD-10. And he was an orthopedic surgeon, so he's like, the hand guys don't want to know what the spine guys want to know. So he broke those up into, I think there are like 5 different orthopedic sections there. So he's broken it down as much as he possibly could to give everyone something that was relevant to their specialty area. But you can certainly look at more than one module and repeat them as you need to. We took everything that's in the ICD-10 manuals, is organized by disease, and we broke them up into subspecialty modules. So we pulled from different parts of ICD-10 manual to give you what was relevant in your subspecialty. Second thing you want to do is learn about comorbidities. Now, you will learn those as you get feedback when you're up in the wards. I've gone over some of the biggest ones: diabetes, the fractures, asthma, acute renal failure, kidney disease. So those will keep coming back at you. And everything I'm saying here today is being taped, so you can go back through it. So those will be a lot of your major comorbidities. The next one is you're going to get the skills from that dual coding feedback. And after October 1st, it'll be direct feedback. It won't be dual coding. Dual coding basically means that they code in ICD-10, but software converts it back into 9 for billing purposes. There is easy software for going from 10 to 9 for reimbursement. There is no easy software from going from 9 to 10. Anyone that tells you that they have a crosswalk has lied to you. There is no crosswalk from 9 to 10. A crosswalk by definition means if this is what it is in 9, this is what it is in 10. That does not exist. Here's what it was in 9, here are the possibilities in 10. So there are websites where you can look some of these things up yourself. You can certainly get books from Amazon.com. They will help you. I would talk to your specialty area, see if they can help you with that. So if you want to do this on your own, you can do that. But again, you really want to focus on documentation and let coders be coders. But if they're in your office, they got to get trained. All right. I think you should begin to explore other resources that are out there. You've got some of the best that are available to you right now. But there's always more stuff coming up out there. There's some medical students invented some interesting little thing that helps you convert ICD-9 codes to possible ICD-10 codes, and then print it all out. It's called ICD-10chart.com. I haven't tested it out, but a lot of people are referring to it, so it's something worth exploring and learning about. Step 5 is to go to this website. This is the CMS website, even though it says .org. It's called The Road to 10. And it's a very valuable site. It's got a lot of good information there. It is designed specifically for small practices, because the assumption is large practices are already moving on this. But The Road to 10 is a good place to start. This is what it looks like when you get there. It is from CMS. There are a lot of different things that are in there. It will take you through a lot of the basics on what's going on, what's different in ICD-10, what is relevant for your practice, some different physician perspectives in case you want to hear from your own specialty folks. The template layer is the part that I like best probably, but you can see there are different specialties. Now, they're not going to give you a lot of detail here, so they're not going to go through all the codes. They'll tell you some basic concepts. This is a good way to actually teach your office staff what's going on, or for people in your office who have not come to any one of these presentations and want just a general overview. It's a good place for them to start. The modules are much more in depth. Here's the template library. So this will let you know what systems you need to be looking at. If you're using a different vendor than the hospital, what you need to be assessing them. If you use a billing service for this, will they even be around October 1st? A lot of billing services are going to have trouble holding on to coders or recruiting coders, especially if they're a mom and pop operation. And they may not let you know until the end of September. And they'll say, well, thank you for all your years of service, but we've decided to retire, and then you're stuck. So we'll check with them early. Okay? If you're working with a clearinghouse, great. Payer assessment, hopefully the hospital will be working with the payers in this area to make sure that they're all up to speed. So at the end of the day, yes, there are going to be some benefits for it. It probably will offer you more challenges than it will be benefits, at least immediately. I would not spend your time learning how to code unless that's something that interests you. The goal is really to make sure your documentation has a level of detail needed and the terminology that's needed. There's still lots of physicians out there that do not know the date, so please let them know October 1st is coming, and let them know what you've learned today about the politics. This thing's going forward. It's going forward, and I really want to make sure physicians are prepared. Let me stop and see what questions you've got. Yes?
If we do provider-based billing, and I'm in my clinic,
Mm-hmm.
and I inject somebody's shoulder for arthritis or something,
Mm-hmm.
shoulder, yeah, does that mean that they will have to do the OWQT67X code?
That's an outpatient procedure.
But if we're a department of the hospital, does that make a difference?
Were they an inpatient?
No. Okay.
Okay? Only applies to inpatients. Mm-hmm. By the way, observation is an outpatient status. Okay? You mean the hospital a couple of days in observation. You're in observation, that's outpatient status. Hmm?
You mentioned before when you talked about the etiology for a problem, I think you mentioned the hypertensive heart disease. And then you mentioned, I believe. And is there a difference between it is due to, is likely due to, I believe it is, it probably is, it possibly is? Is there words that work or do not work for that?
You are expected to use your clinical judgment, and most people will go with it.
So
Most people are not going to challenge it whether or not the heart disease is or is not due to hypertension. Those are not things that people are going to fuss about. Now, on an inpatient basis, you are not sure what the diagnosis is. Probable, likely, and presumptive are acceptable terms. Inpatient only. There are none of these things in the pull-down menu, so don't start looking for that in the pull-down menu. In your note, you can indicate that this is the probable diagnosis. For example, nobody should be admitted for a symptom. It should not happen. We're going to have trouble making medical necessity if it's just belly pain, back pain, chest pain. So you're expected to come up with your presumptive diagnosis. So if it is chest pain, is it GI, cardiac, or respiratory? And then within those, which diagnosis are you going to give to it? Now, if you're giving a presumptive treatment, then why not match it with a presumptive diagnosis? Officers can say, well, what if I'm wrong? Well, the answer is you're wrong because you got new information. That's expected to happen. You're in the hospital. So you say, I have eliminated this previous diagnosis, and based on this new clinical information, here's my new diagnosis. The coder will read that, they will make the change. An auditor comes in, they see it, it's not a problem. This is not comfortable for us, but it is what's expected. So acute coronary syndrome seems to be the biggest term right now when you think it's cardiac and it's chest pain. Now, many physicians argue with me. They said, well, you know, he ruled out. So I called it GERD. And I said, did you prove it was GERD? Did you really prove that it was reflux? Because many coders will say, oh, your your discharge diagnosis is GERD, it will be coded as GERD. And now the hospital will get paid the lowest possible thing because you admitted a patient for GERD. So if you did a workup for acute coronary syndrome because you thought that was what it is, and you're sending them out on aspirin and a cholesterol agent and follow up with someone to better assess their heart, why do you have to change the diagnosis? That was your presumptive diagnosis. That was how you treated the patient. Send them out that way. Ruling someone out does not mean that the cause of their pain was not their heart. Ruling someone out means they are not at risk for an acute cardiac event. Doesn't mean it wasn't their heart that caused their pain. So be very careful how you use those kind of things. So again, it's a critical concept for us. Probable, likely, presumptive are acceptable. They know you can't possibly know a lot of these things. Now, if you have absolutely no clue, you have no way of even making a good clinical guess, that's what observation's for. Observation exists for you to get more information to decide if they need to be admitted. You can put someone from observation and then admit them. You can put them from observation and keep them a second day to get more information. And then admit them. In both those cases, you can put them in observation, treat them, and send them home. Now, observation is a lousy situation for the hospital. They get paid very little. It's a lousy situation for the family because they get a big bill because Medicare does not cover observation the same way it covers an inpatient stay. Observation will not get you into a nursing home except for the fact that social workers happen to be here to do that. But you do not qualify for the financial benefit of a 3-day inpatient stay, simply being an observation. So do not think that everyone should go into observation and we'll just start with that and see what happens. Remember, there's a price that patients pay for that. So you want to use your clinical judgment. People understand that we're not perfect. They understand we're using our best clinical judgment. As long as our treatment plan matches our presumed diagnosis, that's all anyone can ask. Okay? Good questions. Yes?
I have several questions about these modules.
Mm-hmm.
First, you have been listed as specially specific, or whoever has it listed, they're listed as specially specific. I'm going to just take gynecology, for instance, because I do OBGYN.
Okay.
And then in my office, besides gynecology, of course, there's many other things that I do. There are urological things I do. There are screening tests that I do that have to do with general health care and whatnot.
Mm-hmm.
So I do this gynecology module. Do I need to go out and do the internal medicine module? Do I need to go out and do the urology module, or is there enough overlap in these things to be able to just get it from the one module? That's one question.
If you're doing lots of outpatient things, you might do one of the outpatient modules. There's, I think, an outpatient module for internal medicine, an outpatient module for family practice. So if you're doing lots of outpatient things, that might be a module to look through to see if there are relevant things that come up there. Remember, the procedures are irrelevant outpatient. You're still using CPT codes. So you're only looking for diagnoses on an outpatient basis.
There are several modules here that are listed as awareness, education, physician inpatient, physician outpatient. There's also some general ones here that are mentioned as, where the heck is it? I'm sorry. I guess I don't know what the purpose of those are.
Awareness is what you've gone through today. What you'll find, those are a little outdated because they were done back in, I think, 2013. Okay. So I've given you the most up-to-date awareness that there is.
What about physician office, phase 1, part 1, phase 1?
That's really for your staff.
That's what?
For your staff.
That's for staff. All right. One other question.
Mm-hmm.
We have a wound clinic here at this hospital. And
Yes.
I see no modules for wound care.
Okay, well, I would treat it as an injury. And as long as it's getting debrided, that would be an initial encounter, because that's acute phase treatment. And everything after you stop debriding it would be subsequent encounter, because now it's in the healing phase. So it's an injury.
So if we debride it every
It's an initial encounter each week, yes.
Because that's what we do.
That's why I laid it out that way. It comes up a lot. As long as you are acutely treating, it's an initial encounter. In orthopedics, I've found that they put people in the cast and they come out and they're still adjusting the fracture. I'm like, really? Never occurred to me that occurred. I thought you said it and you were done. But as long as you're still adjusting it, that's actually an initial encounter because it's still part of the acute treatment.
But back to my original question,
Okay.
there is no specific module for wound care.
We couldn't do a module for every minor area. We couldn't do it.
I'm not asking you to do, I just
Mhm.
ask if
I mean, the answer is I don't know which module might mention wound care. I imagine there's one on trauma or emergency medicine. So I don't know that particular area comes up.
Okay.
Mm-hmm.
Will the modules teach us some of the diagnostic criteria? Like you gave the one of acute respiratory failure. I had no idea that I could just say they are gasping for air, therefore they have acute respiratory failure. So
That's something your
gonna
clinical
tell me that?
documentation team will be glad to teach you.
So you have
I
to look
threw
at
in a lot of
these
clinical
modules.
documentation there because it is close to my heart. But the answer is they've got all the criteria for all the diagnoses already.
So that won't be covered in the module. So
No.
they'll just say, once you know the clinical, or whatever you called it, so you have to study all that and then apply it to
Well,
all
you
this.
should already know all the diagnostic criteria
I
because
don't.
you've had a clinical documentation program here for quite some time. So apparently, you're saying there'd be a good idea for them to come to your specialty departments and make sure you knew those criteria. I think they'd love to do that.
I've never had anybody come to my office and tell me any of this.
Well, in the back.
May I?
Mhm.
I believe he's referring to outpatient,
Mm-hmm.
the outpatient setting, and our documentation program is specific to inpatient only.
Oh, I see. Okay, you're referring to the clinical criteria outpatient.
Yes.
Sure.
So since I
Probably the one you'll probably need to know, and that's why I say would be the rifle criteria. Because you're going to see acute renal failure there, you're going to see chronic kidney disease.
If they
Hmm?
gasp for air, I can say they have acute respiratory failure. So what are all these other ones that I have no idea that I'm seeing, and I'm seeing it and don't know that it's really some cool condition that has multiple diagnostic codes that I can put to it.
I
Where-
probably
where do you-
covered the biggest ones that physicians miss. The other big one that would be out there, you probably may not see outpatient, but it would be sepsis. Most people think you have to have hypotension to have sepsis, and you don't. So, trust me, all the criteria for anything you would be concerned about, your clinical documentation specialists have it. I know they're only inpatient, but right now, the government is not so focused on outpatient documentation that you're getting nailed for that. The focus is on inpatient simply because that's where the biggest money is. So if you're not doing that clinical criteria on an outpatient basis, for the most part, the government's not going to make a big deal out of it. They're not losing a whole lot of money. And there's no issues really, for the most part, with medical necessity in the outpatient arena. But these become a very big deal on the inpatient arena. And that's where the auditors are spending most of their time.
So, outpatient surgery is not going to be considered inpatient and requiring all the same criteria, et cetera, for diagnosing?
Outpatient surgery will still be using CPT codes and CPT codes only, but because it is a procedure, you must document medical necessity. And there are surgeons who are getting a visit from the government, and these people will walk into your office, they will give you government credentials, and they will say, we've reviewed your surgeries, and it appears that you owe us $50,000. And here are the surgeries we looked at, and here are the things that you failed to document as medically necessary. And they will tell you, by the way, you have the right to refight this and appeal it. If you do, however, we will begin to look at all of your procedures, and if we see a pattern, we will refer it to the Department of Justice. They then walk out of that office with a $50,000 check. So, if you're doing a procedure, remember it's about money. I mean, if you're seeing, someone for primary care stuff, no one's scrutinizing that. But you're making big money because you're doing procedures, government's scrutinizing that. Medical necessity becomes very important.
So since I'm an anesthesiologist, I must depend on the surgeons that have all the documentation.
You are dependent on the surgeons, who are often dependent on primary care folks to get them all the comorbidities that help justify that. The answer is absolutely. Absolutely. But you are key because you are the medical brain for the surgeons. The answer is most surgeons I know don't care whether it's diastolic or systolic failure. They don't care. And I don't blame them, but they're ready to heal with steel, I get it. But someone's got to put that in there. And so you become the key person for having to do that because that might be a problem, for the patient under anesthesia. So you become the key for helping them make sure they're capturing those medical comorbidities appropriately. Yes?
My practice is primarily nursing home and acute nursing home.
Mm-hmm.
What's happening with those codes, if I may ask?
I don't know. I'm presuming that they're going to ICD-10 because the entire health system is going to ICD-10. So clinical trials will be ICD-10. Public health will be ICD-10. My presumption is nursing home diagnosis codes will be ICD-10.
They have code for rounds and acute visits.
Again, if those are visits, now we're talking CPT codes. Diagnoses have to go with every CPT code, though, so that's where you want to make sure you know what appropriate diagnoses that are there. Mm-hmm.
Can we buy tickets for Dr. Wilkes' time in here with you?
Who?
I want to be right up in front.
I only want to be in the back, so I really want to. When's he coming? I want to make it too.
Who?
He must be here tomorrow morning.
You'll find out.
I'll know soon enough.
Okay.
You better
Something to look forward to.
Don't have anything scheduled for at least 2.5 hours after.
Well, apparently they've laid it out that way for me, so. Have lots of questions? Okay. Other questions? Has this been helpful for you?
Yes, yes.
Okay. Thank you very much.
These modules,
Mm-hmm.
does it cost? I guess I don't understand. Why don't they just say, here they all are, you just select the ones. What if I later want to take
You can
one?
see them all. No one's going to charge you extra.
Okay.
Trust me, you let them know what you want to see, they'll be glad to let you see it.